Hi dear students, welcome to another session on hypersensitivity. In the last session we discussed in detail about type 1 hypersensitivity. Now let's check into type 2 hypersensitivity. It is also known as cytotoxic hypersensitivity or cytolytic hypersensitivity and may affect a variety of organs and tissues. The antigens are normally endogenous, although exogenous chemicals which can attach to cell membranes can also lead to type 2 hypersensitivity. Drug-induced hemolytic anemia, granulocytopenia and thrombocytopenia are also examples to type 2 hypersensitivity. Penicillin allergy also belongs to this category. Cytotoxic reactions are defined as those reactions which cause injury to the cell by combining humoral antibodies with cell surface antigens, the blood cells being affected more commonly. These reactions involve a combination of IgG or IgM antibodies with the antigenic determinants on the surface of cells, leading to cytotoxic or cytolytic effects, which includes injury and dysfunction of target cells, and it involves the antibody-mediated destruction of cells and can mediate cell destruction by activating the complement system to create pores in the membrane of the foreign cell. It can also be mediated by antibody-dependent cell-mediated cytotoxicity, in other words ADCC, where the Fc receptors bind to Fc receptor of antibody on the target cell and promote killing. The reaction time in type 2 hypersensitivity is from minutes to hours. It is primarily mediated by antibodies of the IgG and IgM classes and complement. Phagocytes may also play a role, and the lesion contains antibody, complement and neutrophils. This flowchart shows the overall mechanism of type 2 hypersensitivity. In this you can see that the antigenic determinants on the surface of cells in combination of the IgG or IgM antibody resulting in cytotoxic or cytolytic effects. It can activate complement and phagocytosis, which will eventually lead to the lysis or destruction of the target cells. And it can also lead to antibody-dependent cellular cytotoxicity or ADCC. This ADCC is independent of the immune complement system. It can also lyse target but does not require any other cell. ADCC requires an effector cells like the natural killer cells, which can interact with the immunoglobulin G antibodies. So the ADCC can also eventually lead to the target cell injury. The target cells in type 2 hypersensitivity reactions are the normal tissue cell, changed or modified self-tissue cells, and the antigens include the blood group antigen, common antigen, drug antigen, antigen-antibody complex, self-antigen, modified by physical factors or infection. So the mechanism involved in mediating cytotoxic reaction can be categorized into three groups, like the cytotoxic antibodies to blood cells, cytotoxic antibodies to the tissue components, and the antibody-dependent cell-mediated cytotoxicity, that is ADCC. First, let's see the cytotoxic antibodies to the blood cells. It involves direct cytolysis of blood cells by combining the cell surface antigen with IgG or IgM class antibodies. The complement system is activated, resulting in injury to the cell membrane. Cell surface is made susceptible to phagocytosis due to clotting or opsonization from serum factors or opsonins. So this image shows a complement-dependent cytotoxicity. Here you can see the target cell combined with IgG or IgM class antibodies, and the complement system is getting activated, resulting in injury to the cell membrane, and the cell surface is made susceptible to phagocytosis from serum factors or the opsonins. Finally, the target cells will be destroyed by phagocytosis or opsonization or by osmotic lysis. Examples of this type of reactions include drug-induced hemolytic anemia and autoimmune hemolytic anemia. In drug-induced hemolytic anemia, certain antibodies can be absorbed non-specifically to the proteins on RBC membranes. Sometimes antibodies form inducing complement-mediated lysis and thus progressive anemia. It disappears on withdrawal of that particular drug. In autoimmune hemolytic anemia, red cell injury is brought about by autoantibodies reacting with antigens present on red cell surface. Next one is the transfusion reactions. Antibodies of the A, B and O antigens are usually of the IgM class. These antigens are called isohemagglutinin. For example, an A individual produces isohemagglutinin to B-like epitopes but not to A epitopes because they are self. Persons who are transfused with the wrong blood type will produce anti-hemagglutinin causing complement-mediated lysis. Antibodies are usually of the IgG class. Transfusion reaction can be delayed or immediate but have different immunoglobulin isohemagglutinin. Immediate reaction has a complement-mediated lysis triggered by IgM isohemagglutinin. Delayed reactions induce clonal selection and the production of IgG, which is less effective in activating the complement. This leads to incomplete complement-mediated lysis. Hemolytic disease of the newborn. Let's see what's happening in that. Fetal red blood cells are destroyed by maternal isoantibodies crossing placenta. This is where maternal IgG antibodies are specific for fetal blood group antigens cross the placenta and destroy fetal RBCs. Erythroblastosis fetalis is a severe hemolytic disease of the newborn. Most commonly, it develops when an Rh positive fetus expresses an Rh antigen on its blood and the Rh negative mother doesn't recognize it. For the time being, let's take an example where the mother is A negative and the fetus is A positive. During the first pregnancy, small amounts of fetal blood pass through the placenta but not enough to induce a response. During delivery, larger amounts of fetal blood cross the placenta, causing an activation of B cells that are Rh specific, thus leading to memory B cells. The IgM antibody clears the Rh positive cells from the mother. In subsequent pregnancies with an Rh positive fetus, the Rh positive RBC cross the placenta, activating the memory B cells. This in turn cross the placenta and damage the fetal RBC because they are seen as foreign. So let's see what can be done for the treatment of erythroblastosis fetalis. This type of reaction can be prevented by administering antibodies against the Rh antigen within 25 to 48 hours after the first delivery. Rogam is the antibody that is injected. It will bind to the fetal RBC that enter the mother's circulation and facilitate the clearance of them before the B cell activation. In subsequent pregnancies, the mother is unlikely to produce the IgG anti-Rh antibodies. If the mother doesn't receive this injection, there are other ways to treat this depending on the severity. This image shows the development of erythroblastosis fetalis without Rogam and the prevention with Rogam antibody. So when a Rh positive baby is born to Rh negative mother for the first time, the baby will be safe even without the use of Rogam, but during the delivery of this first child, large amount of fetal blood cross the placenta, causing an activation of the B cells that are Rh specific and thus leading to memory B cells, and they produce anti-Rh antibodies. And in the first pregnancy, the IgM antibody clears the Rh positive cells from the mother and the baby will be safe in the case of first pregnancy. But in subsequent pregnancy or in the second pregnancy with an Rh positive fetus, these Rh positive RBC will be crossing the placenta and it will activate the memory cells and it attacks fetal RBCs causing erythroblastosis fetalis. On treatment with Rogam, we can prevent this condition. We can treat the mother with antibody to Rh antigen right after the birth and mother will never make its own immune response, that is, it prevents B cell activation and memory cell formation. The second mechanism of cytotoxic hypersensitivity is the cytotoxic antibodies to tissue components. Here, the cell injury may be brought about by autoantibodies reacting with some components of tissue cells in certain diseases. For example, in myasthenia gravis, antibody to acetylcholine receptors of skeletal muscle is formed, which blocks neuromuscular transmission at the motor end plate, resulting in muscle weakness. And the third mechanism is by the antibody-dependent cell-mediated cytotoxicity or ADCC. It is mediated by leukocytes like monocytes, neutrophils, eosinophils, and natural killer cells. The antibodies involved here are mostly IgG, and the cellular injury occurs by lysis of antibody-coated target cells through Fc receptors on leukocytes. The examples of target cells killed by these mechanisms are tumor cells, parasites. So in this image you can see the antibody-dependent cell-mediated cytotoxicity. You can see the antibody-coated target cells through Fc receptors on the leukocytes, and the reaction is mediated by natural killer cells. Now let's see the diagnosis of type 2 hypersensitivity. The tests include detection of circulating antibody against the tissues involved and the presence of antibody and complement in the lesion by immunofluorescence. And the treatment involves anti-inflammatory and immunosuppressive agents.